Good afternoon and welcome to the Harvard Chan Studio. I'm Adriana McIntyre, Assistant Professor of Health Policy and Politics at the Harvard T.H. Chan School of Public Health, and I'll be today's moderator. We're diving into what's at stake for healthcare in the United States as significant changes in federal policies are expected to impact coverage, costs, and access to care for millions of people, especially for lower-income Americans. Joining us are leaders with on-the-ground experience in two states that will face different policy challenges in this new environment and are likely to take very different approaches. We have Kate Walsh, who until recently served as the Massachusetts Secretary of Health and Human Services and who is currently a Menschel Fellow here at the Harvard Chan School. And we have Justin Senior, CEO of the Safety Net Hospital Alliance of Florida. Justin previously served as Secretary of the Florida Agency for Healthcare Administration and was Florida's Medicaid Director before that. Also, in the interest of transparency, I should disclose that health policy is something of a family business, and Justin is actually my brother-in-law. Today, we are joined in the studio by public health students who are invited to stay after the live stream ends for a Q&A with our speakers. So what's at play here? There's a constellation of health policy changes on the horizon, but we'll focus on some of the issues that loom the largest. At the end of this month, enhanced subsidies that have increased the generosity of financial assistance available under the Affordable Care Act are set to expire. These enhanced subsidies have helped millions of Americans get coverage, with marketplace enrollment more than doubling since they were put into effect. There's still a slim chance that Congress could extend those subsidies, but even if they do, it may be too late to lower premiums for January. Meanwhile, H.R. 1, also known as the One Big Beautiful Bill, which passed last summer, will overhaul the Medicaid program by introducing new work requirements, stricter eligibility rules, and more frequent eligibility reviews. The law also changes how Medicaid is paid for by putting new limits on certain types of financial arrangements that states use to pull down federal dollars to support the Medicaid program. In practice, this means that states will need to either put up more funding themselves or find ways to reduce spending on Medicaid, including potentially by lowering reimbursements to healthcare providers. These changes won't impact all states equally. Many states over the past decade, including Massachusetts, have expanded Medicaid under the Affordable Care Act to cover more low-income parents and single adults. They will be impacted differently than states like Florida that have not expanded the program. Today we'll hear a little bit about how these differences will animate state approaches in the coming years. Justin, let's start with you. Can you briefly explain what your organization does and how it fits into the broader healthcare landscape in Florida?
Sure. The Safety Net Hospital Alliance it functions a lot like a normal hospital association, but we are 14 systems, academic medical centers, children's hospitals, and public hospitals in the state of Florida, about 40 hospitals total. And because of who we are, we see a very high percentage, relatively, of Medicaid patients and a very high percentage of the uninsured. Also because of who we are, we have the ability to actually put up state matching funds because we're public entities and draw down dollars that can be used for graduate medical education in the state of Florida, as well as for charity care and several other programs.
And as federal rules shift, how do you expect people in Florida will be affected, and how will different areas in Florida be affected?
Well, you said that not all states at the beginning are going to be affected the same. There are two things going on. One of the tax credits, the other is the One Big Beautiful Bill. When it came to the One Big Beautiful Bill, it's helpful to think of Medicaid as, it's obviously a federal-state partnership, but it's helpful to think of it as almost a federal menu. A state is designing a healthcare program off of a federal menu, and if they do so, the feds will help with financial participation. Not everybody chooses the same eligibility groups, the same covered services to cover, and there are financing options as well. Most of what happened with the One Big Beautiful Bill did not hit Florida. So they were looking for $880 billion in savings over 10 years in the Medicaid silo when they were doing that bill. And ultimately, if you're looking for that much money, it's hard to escape without getting hit by something. And so where we actually got hit is going to happen in the future, and it's associated with the financing arrangements. It's associated with provider assessments and something called directed payments, where hospitals essentially use assessments against their own revenue to draw down a federal match that is then used to enhance hospital rates. There are a lot of limits on that, and those are going to come to bear over the course of the next 10 or 12 years. It's going to be kind of phased in over time. As a non-expansion state, a lot of sort of the punishing things in the One Big Beautiful Bill were directed at expansion states. I mean, that is the flashpoint. One of the big policy flashpoints is the coverage for able-bodied adults. It hasn't been dropped. It's still a divide, and you can see a divide in the way the One Big Beautiful Bill was designed. The other piece that we're worried about are the targeted are the tax credits. Florida has the largest exchange in the country and always has. I was looking up, there's 4.7 million plus people on the Florida exchange. That is 800,000 more than Texas. It is 2.7 million more than California. And we do have, it's top of mind as a hospital, you have to have, payer mix is everything. You have to have a certain percentage of commercial payers, you have to have a certain percentage of Medicare, a certain percentage of Medicaid, and as low a percentage of uninsured as you can get. A big change to that payer mix, pushing it to Medicaid, pushing it to uninsured, is going to have a major impact on our members' bottom line. They're all nonprofit, they have tight margins to begin with. So it could really affect the mission. And so that's something everybody's really watching closely, what is going to happen to those credits and what potentially might replace them, if anything.
Yeah. And Kate, I wanted to ask you the same question. Massachusetts is obviously different. It's an expansion state. It will see these work requirements and other changes to Medicaid. What is top of mind for you in the policy changes ahead?
I think, first of all, we were headed into this at a time when both hospitals and health plans were kind of still reeling with the after effects of COVID. And what we saw in Massachusetts, and I think in other states, was this significant increase in medical cost trend that we can't quite explain, don't understand, but it's definitely there. And people point to GLP-1s, but if you look at the Medicaid program, there aren't that many people on it. So we can't explain why trend has taken off. There's a couple theories, the introduction of artificial intelligence, both on the payer and provider side, so everybody's upcoding and billing better. But we have a disease debt, I think, that comes out of COVID, and an aging population, and the burden of chronic illness that disproportionately affects insurers and disproportionately affects the Medicaid program in our state here in Massachusetts. So we came into this in kind of rough shape. There are draconian cuts in the bill for Massachusetts, $400 to $500 million, depending on how you count, before you get into the provider tax assessment and all of the other kind of things that happen later in the bill. So it's just a straight up cut of payment. Medicaid's a state federal program. There's a share, and the people who are probably the least costly to insure are most impacted by this program, the so-called able-bodied adults, who are matched at 90% at the federal level. So it costs 10 cents on the dollar for the state of Massachusetts to provide health insurance to an able-bodied individual. That person, maybe spends, maybe on average, between $2,000 to $5,000 a year in care, and that's an average including somebody who had a catastrophic illness in there, and we believed it's going to cost significantly more than that for us to make sure that they are meeting the work requirements. Our view in Medicaid is that in Massachusetts, and we have data to prove this, is that 60% of the people on Mass Health are working. That's the name of the Medicaid program. And the 40% who aren't can't. They're either taking care of somebody disabled, they're disabled themselves, or they have young children. And so the idea that there's some, large swath of people who are suddenly going to be available to the workforce, who are staying out of the workforce because of their Medicaid benefits, I think is just flawed public policy. And we know from experiments that Georgia and from programs in Georgia and Arkansas that the cost of getting able-bodied people far exceeded the cost of their health insurance. So we have work to do as a state to be ready for that requirement because it's on us. And then we have to really watch what happens with the exchanges, because of the people who are on the exchanges in Massachusetts, a big chunk of them are so-called premium supported, and that's where the cuts to Medicaid will really hurt our ability to cover everybody. Massachusetts uses federal dollars as part of a broad compact that started in 2008 with coverage for all, and we're kind of definitely that's in peril.
And as you look ahead, are there steps that you think states can take to minimize the coverage losses? What strategies do you anticipate states might use to try to keep people covered?
I worry that the coverage, that what will happen is, I can't find a better metaphor, but we'll slice the bologna thinner. And I think that it's very hard to take away benefits. So think about, Medicaid in our state is about $20 billion. A lot of it goes to hospitals. A lot of it goes to nursing homes. I mean, what people don't understand is that 70% of the long-term care bed days in our country are paid for by Medicaid. This is, the one beautiful bill is aimed at the so-called able-bodied single male, but it's going to hit his grandmother in a nursing home because that's where the dollars go in our state, or people who get long-term support services so that they can remain at home. And so what I worry about is that we'll try to cover everybody and just do it badly. Absent that, there's probably 2 or 3 things Massachusetts could do. Cut out programmatic services. The one people point to all the time is adult dental. It's something you can cut. It's a horrible cut because it forces people to emergency rooms. And I used to run a safety net system where the lines on Monday morning, before dental was reinstated in our state, were just like around the corner, down the block of people in pain because this is America in the year 2010, couldn't get dental care. So that's one that I really worry about. The other thing I really worry about are long-term support services because often it's sort of a double whammy. The person loses their independence and their ability to stay in their home, and the person who's doing that work, it's a salary that they'll lose largely from a low-income community. And so we're trying to figure out how we can continue to care for people. And then the last thing I think we'll lose are the investments that we've made in population health management, in case management, and we have a broad accountable care program. There are about 2 million people on Mass Health in our state, and 1 million of them are in an accountable care program. That's costly to administer because it's cost above fee-for-service Medicaid, but it coordinates services for people and produces better health outcomes. But I think that's at risk.
Great. Justin, do you want to add anything about work requirements from the non-expansion perspective? I realize that they're not being imposed in non-expansion states, generally speaking. But.
Yeah, we're in a little bit of a different situation. Going back to the federal menu, that is not an eligibility group that we chose to cover off of the federal menu. So when they impose a work requirement, we do have some populations, 19 and 20-year-olds, and we have some able-bodied adult parents with kids that are 14 and over that could, in theory, be impacted by it. But our eligibility thresholds in Florida, it's not just that we didn't choose the expansion population. We choose very few optional eligibility groups. We've chosen to keep a very, very tight program, very focused on the traditional eligibility groups. So the income eligibility thresholds in Florida for 19 and 20-year-olds and for parents, extremely low, often lower than about 20% of federal poverty. The minimum wage in Florida is $14 an hour. If you work even a few hours, you've ended up literally in a catch-22, right? You've earned too much to be eligible for Medicaid, and of course you had to take the job in order to be eligible for Medicaid. Right. So what I think is going to happen, particularly with the 19 and 20-year-olds, is you're going to see it's much more of proving that they are in community college, that they are in training programs and things like that. And I do think there is some experience in Georgia that would suggest that there's almost more bureaucracy and cost created and system costs associated with this than there would be in savings. It just kind of ends up being kind of a break even that doesn't really do much in terms of policy, just because our eligibility thresholds are so low.
Right. I'd like to talk about opportunities here as well. For example, HR 1 provides funding to help support rural healthcare delivery. There are other things happening, both related to and not related to the big, beautiful bill. What excites you about the changing healthcare landscape? Maybe I'll start with you, Kate.
So I think the investment in rural health is overdue, and I think it's really important, and I hope that it won't be just an addition to a day rate for rural hospitals. I can't imagine a harder job than running a critical access hospital. I don't know if you share that view. Yeah. I mean, think about it. You've got, an emergency room, 25 beds in the middle of nowhere, and they can swing between behavioral health and nursing home and skilled nursing, so you need a workforce that's very adept. And how are you ready when a tractor trailer flips over on whatever interstate is near you? I don't know how you do this. And you're doing this and you're often the largest employer in said town. So think about just what that means to the ecosystem of that region. So I think the funding there is really well placed. What I hope it's used for, and what I'm excited about in healthcare, is using that base of funding and that critical access institution and converting it from quote unquote a hospital to a health delivery hub that uses mobile integrated care, that gets out into the community, that that takes the benefit of telehealth and AI and all the things that we think we can use to help patients get healthy and stay well, and be sort of the health hub for the region, not the hospital. Because I think the hospital is a losing proposition, but I think the health hub and the technology focus and the community center and all the good things that hospitals do, they're revered institutions in their communities. And I think if we can help people sort of flip the paradigm to a place to care for a population of people, like, where we all count how long it takes for an ambulance to pick somebody up, the ambulance response time. What if, and this is actually happening in some rural counties in Maine, there's reverse 911. The ambulance drivers actually go to people's houses who they know are isolated and in a rural area, and it snowed last night, did you get food? Like that kind of thing. I think we really need to think differently about healthcare delivery systems. We all like to do what we like to do, and we need to find ways to do it differently.
Yeah, in Florida, we have rural areas really between Tallahassee and Gainesville, and what's called the Big Bend as the coastline turns from west facing to south facing. We also have it south of I-4 near Lake Okeechobee. The way the state is geographically, and every state is unique, it's usually not very far to get to a major medical center. So really, as we look at the rural health opportunity here, it's a way to we've got to think of ways to empower the rural healthcare providers, the rural health clinics, the rural hospitals, the rural practitioners, to kind of get them access to our resources, or in the alternative, kind of project our power into those regions so that they have access to world-class care. Because you want the rural populations, they've chosen to live there for a reason. A lot of people have been forced to leave those areas because of the healthcare situation. They have someone with a chronic condition, they can't drive 45 miles every day back and forth, things like that. But if you can project your power into that area or empower the providers in that area, you can probably get the people in a situation, if we play this investment right, where they feel like they're going to have access to world-class maternity care there, they can start a family there, that they're going to have access if their parents are there, that they have stroke care and cardiac care, that they can stay in that community. And that's what we need to do with that investment. And we'll see how it goes. That's a real promising aspect of this.
Yeah, and I think that's another place where we're just going to see a lot of different approaches across the states, depending on geography, need, all of those things.
But the politics are to keep the hospitals open.
Yeah.
And I think we have to somehow shift that paradigm. And if what the what CMS is asking for happens, I think sort of half the money is supposed to go to new experiments. So I think these guys are fishing in the right pond here if they can make that happen.
And they're moving very quickly. I think we're supposed to get announcements about the funds being dispersed by the end of the year, by the end of this month.
Which is record time for CMS. Yeah.
We have very few rural hospitals in the state of Florida, only 12, but 12 and dwindling.
I want to
There's 2 in Massachusetts if you're keeping track at home.
I want to turn back to the Medicaid financing question. We heard a little bit about how Florida and Massachusetts pay for healthcare differently, and among the changes in the Big Beautiful Bill are new restrictions on the ways that states finance their programs, including a prohibition on new or increased provider taxes or assessments, which have been an important source of revenue for state funding for Medicaid. All 50 states have some form of provider taxes. In a prior conversation, you both described this change as causing states to sort of race to the ceiling. In layman's terms, what did you mean by that?
Want me to take it? So we started out.
I'm no longer employed, so I won't get in trouble for describing it. But
the maximum. There's a federal safe harbor. A hospital, for example, can pay 6% of its revenue as an assessment, and as long as it's 6% or less, then that assessment could be used to draw down a federal match. And in Florida, then it goes to actually enhance the hospital rate. So hospitals generally would be happy to pay this type of assessment. Historically, Florida has not used that often. We were at about 3.5%. The One Big Beautiful Bill said that non-expansion states like Florida were allowed to be at 6% and stay at 6%. But after the date of passage, you were frozen at whatever level you were. So we ended up very quickly, and actually I have to say, it was already in the works to get to 6% in Florida, and to benchmark the hospital rates to the average commercial rate, using that 6% assessment. So we were in that process. It was accelerated a bit. We were able to beat the deadline by quite a bit and impose the taxes prior to the deadline, but that was the race. We actually get to stay at 6% now. We actually got to 5.8 and we get to stay there. However, it's actually going to raise more money than we can use down the road because they've actually limited the rates that can be paid to hospitals, and that's going to go over time from about 200% of Medicare down to, or 220 even, down to 110% of Medicare is going to be the maximum, and that's going to happen in 10 percentage point increments starting in 2028. So it'll be about 2039 when we finally feel all of the cuts, but it's going to happen over time. Short term, we actually got a bit of a boost.
Yeah.
You know,
but your hospitals will be disproportionately hurt because you have no place to cost shift to.
We also see the Medicaid patients exactly, and if they drop out, so ultimately we feel any Medicaid reduction more than others, but we see that we also feel this increase a little bit more than others as well. So it'll be one step forward and then multiple steps back is the way that the bill was set up. So that an expansion state. Some of the expansion states paid for the expansion with these types of assessments, which I think is why they became a flashpoint. And so they're going to get hit a little harder, and I'll let you explain that, I guess.
Yeah, well, I think we were on a path where I'm going to get the numbers wrong, but we were at, I'll say about 5, and we were getting up to 5.8. We hadn't gotten all the way there, but a big part of that money was, I was thinking as you were talking when you talked about the menu approach. Massachusetts was a little more of like an all-you-can-eat buffet, and so I hesitate saying that because it implies that people were just stuffing themselves. But what we were really trying to do is cover people. Like 98% of the people in our state have health insurance. The medical debt in the state is significantly lower than it is in any other state in the union. Our health outcomes are better than any other state in the union. It has worked, and I think the challenge is now that there's less at the buffet table. Where do we spend our money? How do we do this in a way that's safe and effective? And because the other thing is that in our state, and I think this is true in most states, but in meds, eds, and biotech are 25% of the state's economy, period, end of sentence. 25% of the jobs in the state. So if you think about this in the comprehensive view, we're talking about Medicaid financing, but if you look at the attacks the federal government have had on universities, on life sciences, this state is kind of reeling from all of those, and the ecosystem here is really is in peril. And so when you kind of piece it apart, you think about if you go where the money is. The money's in hospital rates. But if you take it out of hospitals, it affects their ability to fund research. It affects their ability to fund clinical trials. It affects the people in Kendall Square who are here because there's clinical trialists who they can test their compounds on. So there's this very fragile ecosystem that these cuts are trampling on. And I don't know how we'll get through this in Massachusetts, but hospital payments are clearly part of it. I think we're going to double down and deepen our investment in primary care. On average, commercial insurance spend between 5 and 7% of their dollars they collect on primary care. Medicaid spends 10, which we challenge the commercial insurance to come to 10 cents on the dollar for primary care. OECD countries, it's at least 15, and remember, they're also supported by much more entrenched social services support. So I think there are things we can do as the buffet gets less appealing to make investments that will get people healthy, keep them well, so they won't need the services in other parts of other times in their life. But that's a big bet, and it's a long, hard policy road to thread. Policy needle to thread.
It's a lot of money
just fractured the metaphor.
Because ultimately, the expansion states are going to get pulled down to 3.5% as the maximum tax rate, and that's going to come in over time, whereas the non-expansion states get to stay at 6 or whatever.
And there's really no rationale for that, except that the expansion states are using it another way.
Where I have to say, we appreciate what happened there in terms of trying not to hurt the state of Florida, in terms of not trying to hurt the state of Texas. What can be done by reconciliation can be undone by reconciliation. It would probably be better if they came up with one national standard that was fair and that people could agree on. And maybe it will end up there. There is time. These things get implemented over time.
Texas didn't take expansion, but they have a $15 billion waiver. It's expansion. if you ask me. But
So, Justin, you mentioned earlier these reforms are part of a suite of policies that are intended to save the federal government money. But you also talk about, a few steps forward for Florida, a number of steps back. What do you expect this to mean for state taxpayers in the future?
So I actually don't know that it will have a huge savings for state taxpayers. It's possible, depending on how they finance their programs, that expansion states might see a savings. It depends on how they finance their programs and how they finance provider groups like hospitals and how they finance directed payment programs for providers, for example. For us, the provider assessment is a bit of a closed loop. That's why the feds hate it. And the feds hate it. There's a bipartisan hatred of it, and there's a bipartisan love of it. It's like it really makes people cross lines.
And they call it money laundering.
Yeah.
Like
So you don't really know how money laundering works.
If you call it that, right? I know.
It's not legalized money laundering.
Right.
If the money's clean, you don't need to wash it. So but yeah,
You
that's
clearly have answered that question before.
It's a catchy phrase. It's a catchy phrase. I think that ultimately, though, our state, like most states, they care about there's a state sales tax that raises revenue. There's a suite of state taxes, corporate income taxes that raise revenue. In other states, there's a personal income tax that would raise revenue. That's called general revenue. That's what they really worry about.
Right.
This doesn't really impact that by going after these sort of side payments. We're probably going to get a little bit of a too bad so sad from the state government as this is happening, but it's not going to be affecting their pot of money necessarily that they really watch and have to have a balanced budget with.
But it is a cost shift, and I think that it's a way. And they'll say too bad, sad on the federal side, but the state has to balance the budget. So it will force cuts. So there's a lot of, I think, hand waving about we're not touching Medicaid, but of course they are.
Yeah.
I mean, and so it ends. If the state of Massachusetts has to produce a balanced budget, and the governor has to sign a balanced budget every year, and Medicaid is $20 billion of a $60 billion budget, where do you go?
Yeah. And it depends on what you use to pay, what you're using the tax to pay for, the assessment to pay for.
Right.
For certain things, there might not even be any savings because ultimately the state could step in with general revenue and backfill it. The thing that means that we are definitely going to take a cut is the rate limitation. When they say you can't backfill it to 220% of Medicare, the maximum is 110. So they won't be able to step in and help the hospitals necessarily. And also there are certain physician groups at academic medical centers they won't be able to help. And they've been at the average commercial rate for years. So that's where they're going to feel the impact the most.
And Kate, you used to be in hospital leadership. How do you think hospitals are going to react? We've talked a little bit about how states might react, but how are the hospitals going to react, especially in expansion states like Massachusetts, where we expect to see some coverage losses?
I've worked at Boston Medical Center for 13 years. I worked at the MGH and the Brigham for 20 years. And in my whole time at the MGH and the Brigham, to my knowledge, a patient was never turned away for an inability to pay. That's a luxury in most states, that academic medical centers of that prominence don't turn people away. In Texas, you go to Harris County. You don't go to Baylor, right? I see a nod, someone must be from Texas, but and so what I worry about is that hospital systems will kind of come together and say, okay, there's work, that safety net hospitals can uniquely do. The problem is they are typically aligned with academic medical centers. Your group of hospitals are the premier hospitals in Florida.
They are.
They have trauma programs, burn programs, all these programs that are often stranded assets, but that the community needs, that you've invested in. So it's going to force choices about who goes where. I think that we haven't quite had to wrestle with in Massachusetts because pretty much everyone was covered. And so can we keep the coverage compact by being much smarter about how we cover people, by making the right investments to get people healthy and keep them well, and somehow have this all work, minus $500 million? I really doubt it. But that's the work.
Yeah, and Kate, I want to stay with you. These expected changes are also going to have rippling effects beyond the healthcare providers, probably to family members, caregivers. Can you talk a little bit about what you expect to see there?
Well, I think particularly for the chronically ill people, people who are able to maintain their independence and dignity in their home because Medicaid supports them through something called LTSS, long-term support services. Those are not paid for by Medicare, and they're paid for people who are severely disabled and or over the age of 65 and dually eligible. We'll have both Medicare and Medicaid. And in our state, those providers are members of 1199 SEIU. They're unionized. We've made a move to get their wages to $20 an hour. Still less than your barista at Starbucks, but a start. We created a career ladder for those people. So it's consumer directed care. So the patient is the employer of their aide, their person, and it's a wonderful program. And I really worry that it will fall apart of their own weight, putting more of a burden back on an already overburdened and completely unpaid family caregivers, group of family caregivers.
And Justin, do you anticipate any sort of similar spillovers in Florida, or do you have any thoughts on how this might affect workforce in Florida?
Well, the main thing, some of the increased eligibility checks and eligibility verifications and some of the additional paperwork may lead to people essentially not going through with the process and going uncovered. They're still eligible for Medicaid. Those people will then show up at our emergency rooms and at emergency rooms around the state, and then we can make them eligible. And their eligibility will be retroactive to the first day of the month or even further than that for certain populations. So there will be coverage, but there is this potential loss of having a primary care provider in a relationship and really kind of following up and really taking care of yourself during the course of the year, and instead it becomes crisis care. So it's something that we're going to have to watch.
Yeah.
We've always had a higher uninsured population than a lot of other states, so it's something that our members are unfortunately used to dealing with the uninsured, which is why we've created programs that help offset that cost in our state for our members as well as for all hospitals in the state. That is the one challenge. That is the way it was before. I mean,
right.
It used to be eligibility was done that way, so we're going to go back to kind of the old days.
What do you think will happen with the exchanges?
For us?
Yeah. Because if the premium support dollars aren't there, are people just going to opt out, which will make them more expensive?
Yeah, so it's a matter of where are they going to land if they do
Yeah.
opt out. I mean, and that's a real unknown. We went from about 2 million people on the exchange to about 4.7 million, and everybody had more than doubled. And I don't doubt for a second that there are some of that. It's Miami. There's some people that don't exist that are getting health care down there, or getting premium subsidies down there. And there are people that are getting those subsidies that have no idea that they're getting those subsidies because a broker signed them up without their knowledge. I don't doubt that is occurring. But I don't also doubt that millions of people signed up legitimately, and now we don't know exactly what's going to happen as we move forward. And that has been a huge help for us because, again, it goes back to payer mix and how you have enough revenue to meet your mission as a nonprofit academic medical center in Miami, for example, Jackson Memorial. You need to have commercial, you need to have Medicare, you need to have these exchange policies, you need to have Medicaid and CHIP, and try to keep that uninsured.
And you need the provider assessment.
Right.
Yeah, and you need to keep that uninsured as tight and as small as you can keep it to have the right mix, and this does create a challenge, and we'll see. It is an unknown.
And marketplace enrollees or would-be marketplace enrollees present a new challenge or a different challenge than Medicaid enrollees, because you can't sort of enroll them at point of service necessarily. There are certain requirements to enroll somebody outside of the strict open enrollment period, which is happening right now and ends January 15th. So there are some real challenges there if people do opt out of coverage.
And it's going to be more people than we think because the economy's changed. I mean, people, it's a gig economy. When you mention Miami, think Uber drivers, think hospitality people, think, it's just a different economic. We have a health care delivery system that's predicated on people having health insurance through their employer. That's just not happening. And so we have to find other ways to fund people, which the exchanges did, or Medicaid does. And now it's going to be a very interesting time for people.
Yeah. Before we turn to questions, many of our students are preparing for careers in health policy, and you both have had, varied careers in this field. What advice do you have for the next generation preparing to work in this rapidly shifting policy environment, and in a policy environment that always seems to be rapidly shifting?
You go first. Things look a little sunnier in Florida.
It definitely is today. I would say that you're entering into a great field, first off, and there's lots of opportunity to really help people and make a difference. What I will say is that health and healthcare and health insurance are three different things, and you're going to have a lot of conversations about those things. But everything really should, as you think about your career and what you want to do, should reinforce health. Right? You're thinking about the individual, you're thinking about the family, and what really supports their health and what keeps them healthy. That would be my advice.
I would say ditto to everything he said, particularly the emphasis on health. And to think, I think we have to start thinking about less being more. Like, I don't know how we can continue to cover everybody for every service. All of you are going to grow up to be great advocates. The best advocates I found are the ones who help solve the kinds of problems we're talking about, not the ones who just say more, more, more. Because I'll tell you, when I was secretary, it just becomes white noise. I mean, you can almost predict what's going to come out of somebody's mouth. The person who comes in and says, I have a solution that's going to bring down your costs, then I'm listening.
And
I'm not that I didn't listen to everybody, but
we find ourselves in a very partisan environment as well. So as you look ahead to opportunities for bipartisan compromise, productive conversations, rural health, what else is top of mind?
well, I think we just had the conversation.
Yeah.
I mean, I think we have two very different states with very different approaches, using federal resources in different ways, but for the same end, to keep Floridians healthy, to keep people in Massachusetts healthy. So I think that there's much more common ground. And it's what I love about Medicaid. You know, it covers 80 million Americans. It's cradle to grave coverage. It's the best behavioral health coverage you can buy, or you don't buy it. I mean, but it's, so, you know, people always talked about Medicare for all. I'm a Medicaid for all gal. I think that our country, you know, we're the richest, most powerful nation in the history of the world. We should have baseline coverage for everybody. And I think it should be what Medicaid covers. I know that's bad politics, and I'll never run for office, but that's what I would do. And I think that it also allows for states to customize it. We have 52 different flavors of Medicaid. We have many states operating under waivers where they can make investments. There are things that Indiana's doing, pretty red state, that are very interesting that Massachusetts could learn from. And I think that I just picked them out of the air, but because I happen to know about some of that stuff. But I think that there's real opportunity in these programs to do better good for people and to use our collective tax dollars wisely. And even if you don't care about Medicaid, you need that population to grow up, live healthy, productive lives, and support the Medicare program. So I think it's a really important investment we should all make.
There's an element of contrarianism in this field where if you thought of it, I hate it.
Yeah.
If I thought of it, you hate it. Right? I mean, ultimately, there is this back and forth. I can tell you, the Affordable Care Act exchanges and the qualifying health plans very important on the left. I can tell you on the right that health savings accounts are extremely important, and the ability to empower people to kind of go out and prior authorize their own care without middlemen and make decisions in the marketplace about what they want to do with their own money. We've got to find a way to marry those two things to come up with a bipartisan solution that empowers people to make their own decisions while still having this backstop of coverage to the extent that the health savings account doesn't cover it.
Which is effectively what the rest of the world does. I mean, you have a baseline government coverage and you buy up if you want something else. It's not magic.
Lastly, I want to riff on this idea of states as laboratories. There are lots of opportunities for states to innovate and provide examples for each other, but there are also limits to what states can do themselves. Can you speak a little bit to that?
Yeah, so I mean, you have to, the so-called 1115 waiver allows you to waive the normal conditions of participation in the Medicaid program. And in Massachusetts, we used the waiver pretty extensively to basically fund coverage for all, but made investments, for example, in food and nutrition support and housing support. California was paying people's rent with their waiver. Like, states do it differently, but all of that has to be approved by CMS. These waivers are on 5-year cycles. People were racing to get them in at the end of the Biden administration. I mean, so it is a pretty ponderous process. And you have to demonstrate success, which is hard to do in a population that by definition is mobile, that by definition is stressed, so for example, we had quality measures built into our program, like how many of the patients with diabetes got regular A1Cs and eye exams and foot exams, and was it documented? And that kind of stuff is, adds to the friction and the cost of delivering health care. I've started to think about it this way. It's probably 30 cents on every dollar we spend in healthcare that goes into some kind of billing, advocating, adjudicating, prior authing, pick the verb you hate. It's like if you went to your ATM and you took out $100 and it cost you $30 to do it. Financial services wouldn't survive. There has to be a way for us to think about everything we've learned about how processes should occur and bring some of that intelligence to healthcare, because I think that's a real opportunity. And I think that that will free up dollars and insights on better ways to care for people. And so, you know, as a public health career, don't shy away from trying to figure out how, you know, just routine systems and routine financial, I said this at the last conversation, understand how funds flow. Otherwise, you will be an ineffective advocate for the programs that you want to preserve.
How funds flow, right? If you get the incentives right,
Yeah.
everything you want to happen will happen.
Yeah.
People will respond to the incentive. That's really consistent. There's a real problem in the country. Again, maybe it comes down to some of the contrarianism that 1115 waivers. All states, a huge percentage of states have 1115 waivers, and this is where the Medicaid statute is from the 1960s, and it's really restrictive in what you can do. And ultimately, 1115 waiver, I always joke, it's like old-time Louisiana. Everything in Medicaid is illegal, but anything can be arranged through an 1115 waiver.
I'm going to steal
so
that.
you get this thing gets waived, and that requirement gets waived, and that restriction gets waived, and you get to do what you want to do. In theory, you're supposed to learn from these waivers, they're demonstration projects, and then that is supposed to inform health policy in the country and make its way into the statutes and the regulations.
It does.
That's not really the way that it's working.
Right.
There was one kind of thing that could be improved in the process, is that things could be lessons could be learned, and then they could become legal, and you wouldn't need a waiver anymore when it's proven that it's an effective delivery system.
All right, with that kernel of wisdom, thank you for joining us today. This event will be available on demand at the Harvard T.H. Chan School YouTube channel, and our in-person audience is invited to stay for an ongoing Q&A. Have a great afternoon.